Hello, good evening. Thank you for having me. It is truly an honor to be here. Now, I'm going to talk a little bit about some of my experiences and what I've seen here in COVID. Of course, my colleague before me, Dr. Martin, who I've known for many years since we were in the same class, took all my time. So it's going to be very condensed and very small. So, but I practice medicine in Baltimore, Maryland. And one of the things that happened during this pandemic was a meeting of the minds. So they decided what was best practice. The leadership has a primer and they go through that, and they have to go through the preliminary think tanks, and the administration has to be set up. They have to decide what public health interventions need to be done, what testing and treatment, and so forth, and what emergency orders need to be done. So what we did here is the governor met with the Maryland Department of Health, the University of Maryland and Johns Hopkins University got together, traditional rivals, but now we had to work together. The National Guard got a field hospital from FEMA, and we set this up in short order. We had to it was a very dynamic environment of shifting events, but that's what we had to do to make sure that this worked. Now, I had a little experience in the military because I'm a flight surgeon in the U.S. Air Force. So setting up hospitals in hostile environments is something that I was familiar with. So, but we jumped on board and we did what we had to do. What we didn't expect was the disinformation campaign that followed. We had to create culturally tailored, community-based interventions and messages so that we can reach people to let them know that a lot of this information was incorrect. So physicians who are usually hidden in the ivory towers and seeing patients and cloaked in the hospital, we had to now come out and we had to start talking to patients and talking to the public to let them know that this disease was real, and we had to start breaking up what all this disinformation was about. So, now everybody has access to a lot of information, but unfortunately, all the information that you hear is not necessarily true. So you have to make sure that it's evidence-based and listen to your leadership. Now, that's what we did here in Maryland. In St. Kitts, what I noticed is they did the exact same thing. You had the initial preliminary processes done. You had the COVID-19 Prevention and Control Act of 2020. The administration came about with the CMO, Dr. Hazel Laws. You had the medical chief of staff, Dr. Cameron Wilkinson. The National COVID-19 Task Force was set up, and you had NEMA. And they have done a phenomenal job. And I just want to emphasize that, just a phenomenal job getting to this point and managing this epidemic. So kudos to them. You also have to make sure that you thank really the folks who were instrumental, right down to the immigration folks, the police, everybody who, and the hospitality folks who are actually kept this thing at bay for almost 14 months. So that's what's important. So I just want to answer a few of the questions I've heard over the last 14 months. I've had a chance to be fully involved in this, be involved in the hospital, in the ICU, in the field hospital. I've seen a lot of death. I've seen a lot of success now coming on to the end of this pandemic, where people are now improving. And so I've seen the worst and now I'm seeing the best. So what your leadership is doing is trying to prevent you from getting to the worst part, because that's what we've seen. So I just want to emphasize that you need to follow the instructions that they're giving, because a lot of research and anticipation went into planning the response to this. So in the hospital, you all are not at that point yet. You haven't had any deaths, but we've had many deaths here, almost 600,000. So, we have to treat these folks, and it's a very expensive proposition. So you don't want your systems overwhelmed. So you're talking about you need your oxygen. And you see what's happening in India with just lack of oxygen. things we use steroids and antivirals, convalescent plasma, and anticoagulants when people are hospitalized, but they're not at the point where they need the ICU. In the outpatient setting, even before they get to the ICU, if they have serious risk factors, we can sometimes give them the monoclonal antibodies, something like Regeneron, and we usually transfuse them if they're at high risk of developing severe disease. So that's one of the things that we do. We constantly encourage the N95 mask, gloves, gown, eye protection, and sometimes we wear the PAPR, which is that spacesuit looking thing, depending on where we are, because the concentration of the virus is instrument in how fast and how rapidly it travels. When you get to the ICU, that's incredibly serious. And this is a little technical. Most folks won't understand that, but you never know. Some doctors may be listening, but you want to make sure you're using buffered balanced crystalloids. You want to use norepinephrine as your first choice and avoid dopamine if somebody is in shock or blood pressure is falling. You want to make sure that an A-line is always present if you're giving presses, and low-dose corticosteroids is important. And make sure you use a higher PEEP strategy. So I know that was Latin to some folks, but just in case somebody needed to get a little guidance, that's how we are aggressively treating those sick people. Now, when you don't survive and you die, I don't want you to forget the mortuary folks on the other side, and make sure that death certificates are filled out completely and thoroughly, because infection control is also important with these individuals, because we're losing a lot of our morticians simply because, some of the death certificates were not coded properly and so forth. And even in the recovery phase, that you're not out of the woods yet. Right now, we have what's called the black fungus, which is mucomycosis, which is a fungus that people get after they've recovered from COVID, and that's spreading in India, and it's killing 50% of the people. So that's serious. And then long COVID. This is side effects of COVID infection, which is prolonged and that continues for a very long time. We're still discovering what that means. And let's talk about variants. Variants keep changing, and that is something we have to pay really close attention to. Right now, the vaccines are able to curb these variants, but we don't know for how long. Right now, there's a variant that came out in Vietnam, which is a blend of the Indian and the UK variant. And anybody who is at risk for whether they're immunocompromised, whether they're on steroids, or whether they're on chemotherapy, you're at risk for developing COVID. So yes, that question of can we get COVID a second time or a third time, the answer is yes. If you get a variant or if you're immunocompromised, you can get that. Another thing I wanted to mention, some people, I know they're saying, well, what about the alternative therapies? What about marijuana? Is that even possible for us to use that? I hear it helps. Well, marijuana, we consider that a Schedule 1 drug, like heroin or LSD or ecstasy. And it has shown some benefits in treating the storm, the cytokine storm that people get. And it's usually young people who are healthy. And what that does is it curbs the cytokine storm. So that is one use that we see, and it decreases the inflammation in the cytokines. So yes, there are some benefits, but we also have to think about the depression, the dizziness that accompanies that, and also hallucinations, decreased blood pressure, increased heart rate, and judgment can sometimes be impaired. So we have to also consider that. Now, my colleagues talked about vaccines. I'm not going to get into the vaccines except to say that one of the questions I heard was, is this a real vaccine? Yes, it is. Vaccines come in various forms and various sizes. Some are inactivated viruses like flu and the polio. Some are weakened viruses like the smallpox and the MMR. Some are the subunit recombinant vaccines, toxoids, where they use the toxin from the actual germ. and your body then builds up an immunity to that. And of course, that goes all the way to adenoviruses, adenovirus-based vaccines, and the mRNA vaccine, which is the one that we're talking about, that folks are saying sometimes can change your DNA. Now, it's very important to know that the vaccine, it doesn't change your DNA. People are getting mixed up with a technique called CRISPR, a technology. And CRISPR is what scientists use to change the genetic blueprint in plants and animals and even human beings. So this is a technique where they go in and they splice out some DNA and they replace it. And it can be used for GMO foods where they can make tomatoes stay red and not go brown. They can use it for mosquitoes, so they can create malaria-free mosquitoes so that they can get rid of the mosquitoes that have malaria. And just recently in humans, they just used a medication called Zolgensma to treat a baby for spinal muscular atrophy. So it went in and clipped out the abnormal DNA, put in normal DNA, and basically cured something that was fatal. So just wanted to mention that folks get that mixed up sometimes. The CRISPR technique is what we'll use. We've had some success with sickle cell disease, but it's not the same thing as the mRNA vaccine, which is not integrated into the body's DNA at all. It's broken down once it delivers its message to tell the body how to produce an immunity. So that's important. Just wanted to mention that. Another question I got, can pregnant women take the vaccine? During trials, pregnant women did get the vaccine, and we didn't really have a whole lot of negative effects from that. Pfizer is actually we can actually give Pfizer to pregnant women now because we've shown that the woman can pass the antibodies on to the baby if they get the vaccine. And also, if she is nursing, she can also pass antibodies on to the baby, and that's from the vaccine. So that's something that we definitely, you'll still want to discuss that with your doctor because there may be some contraindications for you as a pregnant woman. And some research has shown that there's a slightly increased risk of a premature birth. So we want to make sure that we do that. Another question. Can we be vaccinated after we've had COVID-19? And the answer is yes, we strongly recommend that. So some people say, okay, I've gotten the vaccine, so I've gotten the infection, so I don't need the vaccine anymore. The answer is, yeah, you still do, because you get a more robust response from the vaccine rather than from the natural infection. And it's a more measured thing. So once you recover from the vaccine, we're now recommending that you get the vaccine unless you've had a treatment of convalescent plasma or immunoglobulin therapy.